Hello everyone, welcome to Hot Seat Season 2, Session 1. I'm Omid Moghaddas from Tehran, and once again, I'm so happy and honored to be with you all from this platform. And I have to say, first and foremost, I would like to thank all the speakers and all our dear friends who accepted the invitation and are joining today in this platform. And I have a very special guest, a dear friend, Dr. Bernardo Sousa from Portugal, is here with us. Hello, Bernardo. Welcome to Hot Seat. I'm so happy to have you with us.
Hello, Omid. I'm very honored to be here. Actually, as we talked before, your hot seat project, it's now a big thing. You are very famous in Portugal as well for your project, and I have been following the other hot seats that you did in the first season, and congratulations for that, because I think it was very helpful in this quarantine, so dentists could share on a internet-based conference instead of in-person meetings. So this was very, very, very helpful for everybody, and congratulations to you again, because this fantastic initiative.
Thank you so much. Thank you, and I'm so happy to hear that feedback from you, my friend. And I'm super excited that you accepted and joining me today. Though for our dear audience joining this season for the first time, over the past season, we talked about almost different aspects in implant dentistry, from diagnosis to treatment planning, from reconstructions, from prosthetic issues, complications, and in this season, we will go to another level. And what will be greater than this that Bernardo going to present for us, I think, hottest topics these days in full mouth rehabilitations. We will talk about all-on-4 concepts, subperiosteal implants, and so much more that I'm not talking about the details. I'm pretty sure during the presentation, you will get to know so many stuff by one of the people, one of the lecturers that is an expert in this field. So before we start the presentation, I will have a short CV of Bernardo for all of you, and then we straightly go to the presentation, and at the end, we will have a short discussion and Q&A on the topic. So Dr. Bernardo Sousa is a dental degree and master's degree in dentistry by the Portuguese Catholic University in Portugal. Master in oral rehabilitation by ISCSN University in Porto. Former member of the oral surgery and implantology department of Malo Clinic. He's a postgraduate oral and maxillofacial surgery by the of Medicine, University of Havana in Cuba, internship in maxillofacial surgery at the UMC Raad Hospital in Netherlands, and member of the Portuguese National Task Force for Detection and Early Intervention in Oral Cancer. He's an international lecturer about full arch rehabilitation, which we have an honor to be his audience in this platform. So Bernardo, we are ready for your great presentation, and thank you again for joining us on Hot Seat.
Thank you again, Omid. It's a big pleasure for me. Let me check if you can just see everything that I see. So now you see my front page, right? Okay. So I want to welcome everybody that's following these hot sessions by Dr. Omid Moghaddas, and for me it's a big pleasure to start this second season. And today I want to share with you a little bit of my daily work in full arch rehabilitation. This is mostly what I do every day. We will talk about the all-on-4 concept, about subperiosteal implants, about all these techniques that allow us as doctors to deliver a fixed set of teeth to our patients in the same day of the surgery. It's always our goal. It's try to never have to do a delayed loading, but always trying to go immediately. So this presentation will be a little bit dynamic. We will have special content. So just get your phone, we have some QR codes on this presentation, so you can get the special content I prepared for you. In the iPhone, you just need to open the camera, but in some Android phones, you need an app for this. The QR code reader, it's a free app. You can just use it, and you will get all this just for you. So I don't want to bother you so much about the history of dental medicine, but we have to realize that humans always try to preserve their teeth from the oldest civilizations until now. Was and still is an issue on medicine: how to keep your teeth or how to replace missing dentition. And all these findings from all the oldest civilizations trying to keep periodontally compromised teeth with gold wires, with stone, and also with seashells from sea life. And things, fortunately, things evolved. And in the 1940s, Dr. Gudel, it was a Swedish doctor, did the first superiosteal implants for patients who could not wear a removable denture. They didn't have enough bone to have retention of the dentures, and so Dr. Gustav Dell designed this first superiosteal implant that you can see here on the picture on your right. And some years later, Dr. Norman Goldberg was a US Army dentist who modified a little bit design of this structure, which led to the first superiosteal implants. Like we know, I will say similar, but they are quite different in crucial aspects, because the first superiosteal implants that we knew in the 40s, they needed two surgeries to be created. The first surgery was impression of the bone, and then the second surgery was the placement of superiosteal implant itself. This implant was made in a metal alloy, usually chromium cobalt, and they usually apply the overdenture on these superiosteal implants. It was not a fixed solution. The thing is, these first superiosteal implants had severe problems for the patients in the medium term and in the long term. And most of them were due to the mobility of the implant, because this implant was not fixed to the bone. It was just seated on top of the bone, and the gingiva was closing above the implant, so no fixation whatsoever. So the implant started to have mobility, which led to bone exposure, necrosis, increasing the bone atrophy that already existed, and also in the upper jaw, it causes necrosis to the point that we have a chronic maxillary sinusitis because of an open fistula. You can see here on the right the type of bone exposures that we see today on these patients that still have these things in their mouth. They were not fixated, so this led to big troubles. And today it's very rare that we see this type of implants. Most of them failed, and so the term superiosteal implants was almost forgotten until now. We will talk today in this presentation how we changed things and how these things are now working really, really well. So, fortunately, some years later, Professor Brenmark, the father of implantology, discovered the osseointegration. This was after the superiosteal implants that we just talked. So, these findings happened in animal studies in rabbit femurs, actually, to study the blood microcirculation on rabbit's leg. And then after the study, Professor Brenmark went to take out the micro implant he inserted in rabbit's leg, and he found that he could not take out. It was this was how Professor Brenmark found the osseointegration process. He then designed the first implant brand, the Brenmark Integration E, and then this led to the democratization of implantology, and also to the full arch implantology, like we see here on this OPG on your right screen. So this is still the usual today, the typical placement of implants in order to deliver a fixed set. Some years later, also Professor Brenmark in the late 80s, He placed the first zygomatic surgery, and then 10 years after this first zygomatic surgery, the zygoma implants were accessible to the dental community. So in the late 90s and 2000s, we started a democratization of zygoma surgery in order to be able to deliver fixed set of teeth to the patients that have big bone atrophies that we could not help with the regular implants. And then this led to many ways and many doctors placing a different number of implants without much, I would say, criteria. So some doctors would place 4 implants, 5 implants, 6 implants, 8, 10 implants. There was really no guidelines about the number of implants for a full arch rehabilitation. And this was a problem, and things needed to get really straight in this matter. So the first game changer, in my opinion, was Dr. Matson in 1999. This article, it's a little piece of history. You can get it with the QR code on your screen. So this was the first study describing a technique that would be the Allen for some years later. You can see here the drawing by Professor Matson, the initial tilting of the implants. This was unthinkable in 1999. So this was the first time it was published. You can see one of the first cases used tilted implants here. This case was with 6 implants, but you can see how the threads are exposed on the palatal side. So this was a very extreme case done in 1999. If this today is okay for us, you can just imagine how extreme this was back in those days. And then some years later, Professor Paulo Malo in 2003 and 2005 launched the first Allen for articles. First one in 2003, it was on the mandible, and then 2 years later, it was maxilla Allen for. And this is exactly what we will start talking today. How to place this, why to place 4 implants, why to tilt implants, does it have any complication, any increased bone loss, increased implant failure rate? Let's see what they say about this. We are all dentists, right? And you know this so well as me, Omid, that every time someone does something which is a little bit out of the box, it's always involved around a lot of criticism. And the Allen for and Malo was no exception. Actually, the Allen for technique is still today very criticized in many parts of the world, and in many actually in Portugal, right? Paulo Malo is a Portuguese dentist, and still in Portugal there is a lot of criticism about this technique. So we need to prove 2 things about tilting implants for the Allen for. So it's comparing straight and tilted implants, if there is any difference, and comparing the number of implants for the rehabilitation. So let's see what the literature says about straight versus tilted implants. We have one of the biggest and most important studies, in my opinion, is this one by Antonio Zampellis, which try to compare the 2 situations and see what was the bone stress in the bone around the implants with different degrees of tilting. You can see here on graph with 0 degrees of tilting, 10 degrees, 20 degrees, 30, and 45 degrees. And we can see that the bone is more or less the same, independent of the degree of tilting of the implant. So different angulations result in the stress bone. So this was the 2 conclusions about the study. Tilted implants don't increase bone stress, and it's better to tilt in order to avoid the cantilever. This is exactly what we will see around following this presentation. But we needed more, right? We cannot use small studies to say something like this. On the pyramid of scientific evidence, we needed systematic reviews and meta-analysis to show us this. And the first meta-analysis came in 2012. So oral relation with tilted dental implants. Let's see what they found. they found that tilted implants have the same success rate and the same marginal bone pattern with straight implants. This was the first meta-analysis to say this. 3 years later, we have the second meta-analysis about the subject by Bruno Čarkanović. He's a very famous author about the Allen-Ford and tilted implants. He also compared the straight and tilted implants and came to the exact same conclusion, that tilted implants have the same success rate and the same marginal bone loss compared with straight implants. So we compared straight and tilted, and for now we know the bone stress is pretty much the same. Let's see what literature says about the number of implants. 4 implants compared with 5 or 6 implants. We have the first study, it's actually by Professor Brandmark. So he did a 10-year study. It's very difficult to have a 10 years follow-up with patients, as we all know, and published it in 1995. So remember, he started to study this in 85, and he studied 156 edentulous patients for 10 years, comparing 6 and 4 implants. You can also get the study if you get this QR code with your phone. And the conclusions were that the survival for both individual implants and the prosthesis was the same in both groups at the end of the 10-year observation period. And also, Professor Brandmark went a little bit further when he says that the present tendency of some clinicians to install as many implants as possible in full edentalism should be seriously questioned. Remember, this was in 1995. And so, in 2000, let's see what biomechanics studies say about 4, 5, or 6 implants per arch. This first study by Doik in the year 2000 was a very complex study. You can also get it with the QR code. He found the difference in loading conditions between 6 or 4 implants has no clinical relevance at all. Also, this study by Marcos Naconecci, a Brazilian author, very famous about studying tilted implants as well. You can also get this study. This was a very complex study, compared 3. When they say abutments, they are talking about it. So 3 abutments, 4 abutments, and 5 abutments. And at the end of the study, comparing bite forces, lateral forces, hinging movements, bending movements of the structure, he came to the conclusion that tilted implants resulted in lower stress in bone and prosthesis with 4 or 5 implants in the similar way. So they didn't find any difference between 4 or 5 implants, but they did found when they placed only 3 implants. So we know that with 3 implants, stress is a lot higher than 4 or 5 or 6 in the same way. So we needed big follow-ups, right? Or everybody wants to hear numbers with lots of follow-ups. It's one of the critics of the technique of any technique, actually, to be honest, is but you don't have follow-ups. Well, now we have. Paulo Maló published last year 13 years follow-up in the maxilla with a 95% survival rate and 94% success rate, a marginal bone loss of 167 millimeters on 10 years, and in the mandible, the 18 years follow-up. This is the biggest full arch follow-up study published so far. It's almost 20 years. They found 93% survival rate and 92% success rate with less than 2 millimeters of marginal bone loss on an average 10-year period. This is very inspiring results, and we can't really get much longer than this in terms of follow-up. So we need to really stay on what we know for sure. We need to stand up for science, and today we are living on an era that we have a lot of myths and misconceptions being spread out by the media and by social network, like the earth is flat and the science are something to manipulate the population. But we really need to stand up for science, and the Allen-Ford really works, as you have seen in the previous This was to a point that the international community that has been criticizing so much the All-on-4 concept had to say something, and the international census only came in 2016 when the ITI finally said that there is no increased risk for implant loss in posterior tilted implants in the mandible and in the maxilla. He also said that the treatment protocol with at least 2 anterior straight and 2 tilted implants in the premolar region can be considered a valid option as long as the clinician has appropriate education, experience, and skills. It was a big statement by the ITI that came in 2016. So, what would be the ideal full arch solution in 2020? For me, an ideal solution for this type of cases would be a fast solution with no dedicated relations that allow us to go immediate loading with a cleanable prosthesis with high success rates and a reasonable cost for our patient. Solution that has very few complications, and we can find all of these characteristics on the All-on-4 technique, as we have seen, and I will show you with many examples later in this presentation. Here you can see the mandible All-on-4, here you can see maxilla All-on-4, and I'm going to show you later the extreme possibilities of this technique. So let's talk a little bit of basic fundamentals of the concept. First thing is a wide flap. We cannot do what we cannot see. And I remember when I was studying in middle school about the 3 main principles of oral surgery by Peterson. We have to memorize this for the test, which was illumination, accessibility, and visibility. So a wide flap will allow you all of this, and it's the basic fundamental number 1. Second one, bone reduction. Most cases, I would say 99% of full arch cases will need some degree of bone reduction, and it's a big topic. We have talked many times in the Full Arch Club, and it's very common that colleagues ask me, what tools do I use for the bone reduction? You can see these, sometimes you have to go all this way, more than 10 millimeters, in order to hide the transition zone, or if we have any other aspect that we need to be aware in order to know how much bone we have to reduce. So, because many people ask the tools I use, I want to show you a very, very small video, so you just can see that usually I start with the bone ranger, because you can just remove the bone, but you get the bone, you are not wasting the bone, you keep it, and you can then use later if we have sockets to fill. This way you keep almost, I would say 95, 98% of the reduction that you made with the bone ranger, you just keep the bone. This is the most precious bone of all, and it's free. And this is the first step. So most of the reduction we are doing with the bone ranger. And then after we collect the biggest part, we just use this flame-shaped burr in order to make a good plateau of bone for the proper implant placement. These are the only 2 tools I use. First the bone ranger, and then this type of acrylic burr, very large head, so the bone profile stays really flat. The smaller the burr you use, more irregularities you will have on the bone. The trick is to have a big burr to do this. Sterilize it, of course, and with not many uses, because it loses the power for the reduction. So, following the next fundamentals, 4 implants per arch, as we all know, and tilting the posterior up to 45 degrees. The tip of the implants are always anchored in dense bone. We know in the maxilla, the area around the nose, and the area in the mandible, in the mid part of the mandible, and always go with immediate loading in this type of cases. We can have some cantilever if necessary, up to 15 millimeters, it's okay. More than 15 millimeters, we may have some troubles with the infrastructure, and the use of intermediate abutments every time, not only because the intermediate abutments have angulations to correct the angulation of the implants, but also because of the one implant, one abutment at one time concept. So we place the implants, we place the abutments, and I would say it's very rare that we have to change any of these multi-unit abutments. So we get a very good hemidesmosomal sealing of the cells of the inner part of the implant around the collar of the multi-unit abutments. It's not the same like the sealing with a root, for example, with the perpendicular Sharpei fibers, but it's a sealing that is tight enough to avoid the penetration of bacteria and food and foreign bodies to the implant. And of course, high primary stability. This is a key factor for the immediate loading, for any immediate loading protocol. I would say the most important factor is to have high primary stability. So I'm just going to show you some cases really quick. You can see here the position of the anterior wall of the sinus and tilting the implant to avoid the sinus. Here in case number 2, here you see the place of the anterior wall of the sinus and the placement of the implants, avoiding that, and always with immediate loading. You can see here case number 3, also very close to the sinus. You can see case number 4, the same situation, the same concept, tilting up to 45 degrees. The same here with case number 5, getting really close to the anterior wall of the sinus. So we can also benefit from the hard cortical of that wall. Every bone wall is cortical, right? So the closer we are, the most we benefit from the cortical type of bone. Here you can see the same situation, also in the mandible, looking for 4 millimeters safe distance from the nerve. There is actually no need to go closer than this. You may have some troubles in the future, and this is something that you really want to avoid. This is the type of nerve exposure we do in this type of cases. So we cannot miss what we can see, right? So by exposing the nerve, we know what we are doing, we know our safe margins, and we all sleep very well at night. So for this type of angulations, we have these guides. Nowadays, there are several types of guides on the market. These of them have vertical laser marks, and some of them also have tilted laser marks in 30 and in 45 degrees to help you with the angulations. So this is the use in the maxilla. You can see how we place this in the midline, and most of times I use the nasopalatine canal because it's already a socket, right? We just use a little bit of the 2.0 drill and inside the nasopalatine canal, and we place the guide. And here you can see placement of the guide in the mandible, and you can see the reflection of the drill on the material of the guide. So this is very helpful that the guide is reflective. The opaque ones don't reflect drill, and you have to bend your head to try to see how many degrees you are working with. If you have the reflection, you can just look a little bit and you know you are on the right spot. This is why, because this type of guides that don't have the tilted marks, they work like this. From one corner to the opposite corner, we are tilting 30 degrees. And from that corner to the middle of the next rectangle over here, it's 45 degrees. So by knowing this, we know how much tilting we are doing. This is also something that people ask a lot. A lot of colleagues have doubts about the guide. So I want to show you this small video about the placement of the guide. You can see here the nasopalatine canal, right? And I am just going to use it with a 2.0 millimeter first burr to open a little bit of the channel, just enough to place the guide. There is no need to make another hole for this in the maxilla. You can see here, the guide is bendable, so we can adjust it to the shape of the arch, and we can see here the reflection of the drill on the guide metal. And this is how we use the guide. One question also very asked is if we tilt the implants, even if we have enough bone to place them straight. You know, that cases with a big amounts of bone. Hey, Bernardo, if we have a good amount of bone, why are you tilting the implants? Are you tilting? Why are you doing? Why are you not doing this? I would say that most of the times, yes, we still tilt the implants in this type of cases because of primary stability, as we were talking before. We know the maxilla is always the trouble, right? It's not the mandible. Maxilla is always softer bone. And we know that in the anterior maxilla, we find the best bone of this arch. It's between both sinus that we have the best bone, particularly around the nose, because the nose cortical is very, very hard. And in this area, we have the best bone quality on the maxilla. In the mandible, it's kind of the same. It's between mental foramen that we have the best bone available in the lower. This is exactly where we want our tip, the apex of our implants, to engage. So this way we have high primary stability, and we can for sure make the immediate loading in our patient because we have high primary stability, high torques of insertion in our implants. That's why I still tilt the implants even if I have enough bone to place them straight. I was talking about the nose wall anchorage, and I want to show you what we mean by this. We mean intentionally penetrate up to 2 millimeters inside the nasal fossa. We expose so we can measure it, and we place the tip of the implant a little bit, getting this bicortical anchorage in this very, very strong bone, because sometimes even the anterior maxilla is softer bone. It's not very usual, but it happens. And when that happens, decorticalization in the nose wall is very helpful, as you can see on these slices. Here. I want to show you some quick cases about the upper Allon 4 technique. You can see fully edentulous, you can see the type of incision, you can see the aspect after flap release, the placement of the guide. After bone reduction, you can see very yellowish, very fatty bone, very soft bone, and then the placement of the implants, placement of the multi-unit abutments, and loading in every case. The lower Allon 4 case, you can see here the occlusal view, you can see here the placement, filling up the sockets with all of the bone that we collected with the bone ranger we were talking before. We place no bone substitutes, only autologous bone, and we don't need to place any membrane over this. Just close the flap and you will be just fine. 3-4 months later, it's all filled up with natural bone. You can see here this upper jaw, a little bit of a thin crest, but after the bone action, we have a nice plateau, and now we place the implants, high primary stability, bicortical anchorage, and immediate loading. I want to show you also this same case on the mandible. This is the same patient. He wanted something very cheap, so we did this truncator system, but notice that we have done the bone reduction exactly in the same way as we were going to do an Allon 4. Because if this patient later wants to upgrade the solution for 4 implants, we already have the bone prepared to do it. And this was exactly what happened. This was 2 months later. The patient came to the office and said, "Hey doc, I really like the upper solution, the fixed Allen-4. I want the same in the lower. So we did these semi-incisions, not to have to make incision in the keratinizing mucosa here. And we just placed the 2 posterior implants. And we did the immediate loading as well in the lower jaw. I want to show you some more cases. A BMAX Allen-4. You can see the hopeless teeth. And after the implant placement in the upper jaw, you can see a little bit of a thin crest, a little bit palatal positioning of the implants. And the same in the lower jaw, the placement of the implants, and fill it up all with all bone collected from the bone reduction with the bone ranger. And always immediate loading as we do it in every case. I want to show you here an Allen-4. You can see thin crest on this case, but after bone reduction, in order to hide the transition zone and also to get the plateau of bone, now we have enough plateau to place the implants and to perform the immediate loading as well. I want to show you also a funny case of Allen-4 and sinus lift in the same situation, because sometimes it may happen. We have this big cyst, you can see here on the first quadrant, is mucocell, big retention cyst. So this patient came to Portugal. She lives in Luxembourg. She wanted a fixed suit for the upper jaw with the minimum amount of interventions as possible. And so what we did on this patient was the removal of the cyst, the sinus lift at the same time, and the Allen-4 procedure at the same moment. You can see this was the sinus lift and the Allen-4 in one step. Why did we do this? Because here you can see that we have a little bit of a cantilever, right? Compared to the position of this implant, this may be problematic. So we did the Allen-4, we did the immediate loading, but now we also have room to place one implant here if we have troubles with this liver in the future. So if she wanted an immediate loading solution, that's exactly what we searched for it. Also in the lower jaw, we have tilted the posterior implant in order to avoid the horizontal augmentation in this area. And so the OPG would look like this with the regeneration of the sinus here, but we did the immediate loading as it was, as it is always our goal. Our mission is to deliver things immediately to our patients. I want to show you an extreme case of bone reduction. You can see this patient with huge posterior overgrowth of soft and hard tissue. See, this is the frontal aspect, lateral aspect on both sides. So we expect bone reduction in this type of cases because it's not okay when patient smiles to see the transition zone, even if it's only in the posterior area. So this type of cases require a huge bone reduction, not only on the upper but also on the lower. This is the lower jaw before bone reduction. This is after bone reduction. Now you can see the plateau. Everything is healthy bone right now. And this is after implant placement. You can see both arches completely flat and immediately loaded. This was exactly what we were looking for. All of this has to be hide, and this is where we want to start working on prosthesis. So this is the final healing. And this is the OP before and after. You can see here the sinus is really at crestal level, and you can see here the position of the sinus where it was. So this is not what we like to do, but this is the necessary. This is what we have to do in order to deliver a nice cleanable prosthesis hiding the transition zone. Patient was like this, and now she looks very happy. She did again and changed the job, and everything is a completely new person, and we are very happy for her. I want to show you this type of extreme atrophies, very thin maxillas. This is the real deal, very thin and very soft maxillas. In this type of cases, we can do a little bit of a deviation of the Allen-Ford procedure that we call the palatal approach. The palatal approach technique is a slight modification of the Allen-Ford where we intentionally leave exposed threads on the palatal side, never on the buccal side. These threads will not be grafted, no bone grafts, no membranes whatsoever. We will leave it like this because the palatal mucosa is the best soft tissue of the maxilla. The connective tissue, the connective keratinized tissue of the palate will make a very, very tight sealing, not only at implant level, but also at multi-unit level. So this is a hemidesmal sealing that will be more than enough. If and only if we have very good primary stability in our implants. So the trick, once again, is high primary stability. We cannot have any micro movements on the implants. And if we do that, the chances of a failed implant are very, very low. This is a detail of what type of exposure we can allow to form, also in the anterior area. This was the case. This is the implant placement, and I want to show you what happened at 4.5 years. Actually, it's more 5 years now. This very, very nice healing, and I don't think much colleagues would say that this case was so thin just by looking at this occlusal picture. The thing is, always have good keratinized only on the palatal side, but also in the buccal side. I want to show you here another deviation from the technique for type of extreme cases. You can see here the second quadrant. I'm going to mark here the real position of the anterior wall of the sinus. In this type, we cannot tilt around this area, the normal area, because it's too big of a cantilever, and we cannot go transsinus because we don't have the minimum crest to go transsinus. So in this type of cases, we can use the pterygoid area and still allow us to go for immediate loading. Here is the occlusal picture. You can see here the pterygoid implant in place. Always it immediately, and 3 years follow-up right now, it is looking like this. I want to show you another recent approach for this type of cases, which is the transnasal approach. This video is very heavy, so I will just change here a little bit. I will show you like this. I'm going to go forward a little bit because I have the whole surgery here. You can see here the upper jaw and the nasal floor being retracted. These instruments are the same for the sinus lift. And the idea on this technique is to use 3 corticals. So the first cortical is when we enter with the drill. The second cortical is the floor of the nose. And the third cortical is the lateral wall of the nose. So this type of case that we don't really have much height of bone because we have to reduce, and then we have like 5 millimeters only until the floor of the nose. We need a bigger implant, we need more primary stability, and we can do this transnasal approach very safe. Just going forward a little bit. Okay, so now we see here. So this is crossing three corticals, the first one on the crest, the second one over here, and the third one on the lateral part of the nose. Now you will see the same, you see here the anchorage on the lateral wall of the nose, and you can see here the same on the other side. This is, with this technique, we get extreme high primary stability. We need to be careful not to get too much in order to don't break the transfer or the implant, because really high primary stability doing this technique. You can see here crossing three corticals. And this is the final aspect. You can see here the tip of the implant a little bit inside of the lateral wall of the nose. Okay. So this is exactly what I was talking about. In a very resorbed maxilla, we can place the implants in this position. This is actually the way the implant goes, crossing the three corticals, getting really high primary stability, and then we just place the regular Allen fork. You just need to be very careful so the tips are not touching each other. If they touch, there is no big problem, but it's something we need to be careful while placing this type of implants. And when there is nothing left, extreme resorbed cases, are we going for anymore? We don't. Actually, from some years now, we just stopped completely the zygoma surgery because of the problems of this technique. It's a very useful and it's a wonderful way of extreme cases, but when there are complications with zygomatic implants, these complications result in very serious consequences, like you can see on this case right here. So in order to avoid this type of complications that are sometimes unsolvable, and the patient may have to deal with a removable prosthesis for the rest of the lives and with no retention whatsoever, we are doing now the nouvelle vague of subperiosteal implants, as I like to call it, this nouvelle vague. So what is the difference between these subperiosteal implants and the first subperiosteal that we talked just in the beginning of this lecture? These new subperiosteal implants are, first of all, CAD/CAM manufactured. So we are not making impressions of the bone anymore. Everything is by CAD/CAM, and the material is pure titanium 5 grade. They have a hybrid surface, which means that the surface of the implant that is facing the soft tissue is a polished surface, and the surface of this facing the bone is an SLA treated surface, so like a regular implant on the inner part. This implant has under application. What do I mean by this? You can see here where I'm pointing, we have to prepare the bone. So we have to prepare these small channels so the implant structure is a little bit under the crest, is not on top of the crest. Why is that? Because the muscle insertion will create the exposure of the implants, like we see on the other ones. We don't want any muscular activity on the crest by pulling the tissue on this area of the implant, because once we have an exposure, it's very easy for the exposure to get bigger and bigger and bigger, and you may have a big problem. So by doing these channels, we place under the bone a little bit, just enough, so we don't have this type of mobility. This implant is also screw retainer and screw integrated. What it means is the screws are not normal screws that we use, for example, for the Kouri technique, but these screws are made out of titanium. So they screw and they integrate at the same time. And this is a multi-unit connection. So these four connectors here will receive a usual multi-unit on top of them. So I want to show you here some cases of these implants. You can see here, I will show you this CVCT, the type of atrophy. See here that we have almost nothing. You can see also here the cross-sectional slices. So this is our crest. We have absolutely nothing. And so you can see also here, very, very atrophic maxilla. And so Bone Easy, which is the manufacturer of these implants, just designed this beautiful superiosteal implant, as you can see, with two zygoma fixtures in each zygomatic bone. So very hard bone, very cortical, very good primary stability. You can see the design over here. Notice that the placement and the position of these screws is always looking to achieve a high primary stability. So we are always looking to place these mini screws in areas of very quality. And so this was the case. This is the of this patient. This is the placement of the implant. Notice the bone channels that we have to create in order to fit the structure. And you can see here the placement just below the nose. And the 2 years you can see very, very good keratinized tissue all around, which is crucial for these implants. Remember, it's very difficult to make perform a free gingival graft in this type of case because we have all the structure. So the gingival graft, if we have the part of the implant, for example, in this position, we cannot place the gingival graft. It will have a necrosis. So in this type of sometimes we need to add soft tissue before the placement of the implants. Otherwise, we may not have the results that we want. This is the final OPG. You can see here the placement in both zygomas. And another case with no remaining bone with existing signation. You can see here in the second quadrant in both pictures the existing communication. I'm going to show you really, really quick the area. You can see here. And so Bone Easy again designed this beautiful implant. You can see the concept, both two mini screws on each zygoma, screws all around the nose and here in the midline of the palate. Very, very good primary stability always. You can see here the positioning of the screws, aiming for the vomer bone. And this is the implant as we receive it in our office. You can see very clear the part that faces the soft tissue and the rough, the part that contacts the bone. This is the superiosteal implant in place. You can see here, these three ones are on the midline of the palate and the double fixation in the zygomatic in both sides. This was the final OPG. The quality is not so good. I'm sorry for the OPG. And I want to show you of a superiosteal implant now with extractions. Both these cases were in fully edentulous patients, now with some extractions along the way. Very, very atrophic maxilla. You can see here on the video design of the implant and the type of extreme resorbable arch that we have. So Again, Bonizzi designed this beautiful implant. This is the way it comes. You can see here the mini screws I was telling you before. So they are titanium. They will screw and they will integrate in the same time. This is the inner part of the implant. You can see the polished surface, the rough surface, sorry. So this is facing the bone. This is the guide. This is a guide for the channels, for the perforations we have to do on the, in order to sit the implant. And this is the implant in place. You can see here the preparations as well. But you can see these preparations are minimum compared with the zygomatic or a quad zygoma type of approach. We still have the zygoma. Remember this. Even if all of these fail, we can repeat this or we can go still for the zygoma. So the last resource is really a last resource. You can see here the occlusal. See, this was so resorbable, resolvable axilla that even the palate is a little grayish. So very funny to see it on the picture. So this was the final OPG. And also we have case on the lower jaw. This case is by Dr. Americ Sampaio, great friend and also a Portuguese dentist. You see here this extreme resorbable mandible. The nerve is exposed on both sides. And this was the design of the implant, also by Bone, which is a Portuguese company, by the way. This was one of the first designs we were working in 4 years ago. Now the design is a little bit different, but you still can see the concept. And you can see here the implant in place, already fixed. We didn't really have to open everything. We just needed to open in the place the implant had to be seated. So this type of design allows us to be conservative in this type of aspect and not injuring the nerve, because it was really on the soft tissue. And here, final occlusal picture, and PG of the implant in place. This case is now almost 4 years, so with great success, one of the first cases of the subperiosteal implants, this new novel valve on the mandible. So we are very happy for this patient. And I want to finish with partial atrophies. So these type of solutions, we don't use them only for full arch cases, but also in partial cases. Look here on this, on this quadrant, you know, the posterior mandible is always a big deal. So this was the aspect of this quadrant. You see here the depression, big defect, both soft and hard tissue. So we first started with a depithelialized free gingival graft to have better tissue profile. You can see here the graft. So the graft was all placed inside the tissue like this, because the goal here was not only to get the keratinized tissue on the buccal side, but to get thickness. So tissue with good thickness for this type of implant will prevent the exposure, because the exposure of the implant is the real problem with this solution. Fixation is not a problem. It's very good anchorage, because the screw really offer really good primary stability, but the problem is always with the tissue. So you can see here how much we gained only with the soft tissue, and now we are in conditions 10 weeks later to place the implant. So this was the design of the implant. So by this way, we are avoiding vertical regenerations in the posterior mandible, and we still apply immediate loading in partial cases with this solution. You can see here the position of the screws relatively to the nerve. Careful positioning, of course. This is the implant as we receive it. you can see we also add this lingual part to prevent the mobility, the buccal lingual mobility, which can happen. It's a posterior region, remember, heavy bite forces, and here the guide to make the channels. So this was the implant in place, lot of screws, very good high primary stability, and immediate loading with no problem whatsoever, and this is the implant in place. So this is my final message, not related to implants, but related to life in general. And I'm pretty sure that you also relate with this, Omid. Is everybody wants success, but only until they know what it actually takes. So all of these things, all the things that we see on social media, on Instagram, those beautiful pictures, everything seems very easy, and everything seems like one day you don't know and the next day you are a pro. Things are not like this. Everything takes a lot of time, takes a lot of trial and error, and sleepless nights trying to learn, trying to get the details in a video. A small detail will change sometimes your whole procedure. And so to younger friends, this is my message to you. All these things take a lot of time, take a lot of sleepless nights, but just go for it, because it's impressive how we can help patients that have sometimes hopeless situations, and their final satisfaction with you will be better and more, how can I say, and more inspiring for you than all these troubles that you may have during your life while trying to learn and trying to do the impossible for this type of patients. So keep doing it. Don't lose faith, because there are no shortcuts to success. Thank you all.
Thank you so much, Bernardo. I have to say, I myself enjoyed every second of the presentation. As I said at the beginning of it, it's a whole different way of on all-on-4 subperiosteal implant, and as you said, the return of subperiosteal, because so many people still think that it's the same as years before and those problems that subperiosteal implants had. But we know now, and as you beautifully demonstrated that, because you're one of the people that really worked on it, that everything has changed, and there are very small tips that we should take into consideration to make sure everything goes perfect. So again, thank you so much. And now good to go for some Q&As and, have a little discussion on this impressive topic that you really presented to us. One that before I forget to ask you, what is usually the thickness of those periosteal implants? Should they be the minimum thickness? Is there any criteria or range for that? Can we have any information on that?
Yes, thank you for the question. It's a very interesting question that a lot of colleagues have asked me. This type of superiosteal implants, they have to be thick enough to resist torsion, but they cannot be too thick, because otherwise they will expose. Look, when we use titanium meshes, for example, for augmentation, even those titanium meshes expose very, very easily. Of course, it's a different thing. Of course, we are doing augmentation, but here we are working at bone level, actually a little bit under bone level. So these implants can be a little bit thicker than we are used to work with, because of this undercrestal positioning. So they have around 2 millimeters of thickness. It's a technical detail. It depends case by case. Bone Easy designs the implant according always the anatomy of the patient, anatomy of the maxilla, the type, the positioning of the connectors and everything. But it's around 2 millimeters. But yeah, but it depends. It's not always even through all the implant in the same way. But sorry.
Customized for every patient, but the mean thickness is about 2 millimeters, right?
I don't know for sure because that's a very technical aspect of the implant, but I would say that 2 millimeters, it's the maximum thickness that I have seen in all the superiosteal implants that I have placed. I would say up to 2 millimeters, but I really don't know for sure. But I know that Rui Coelho from Bonisi will be more than happy to talk about all these technical details.
Sure. And Bernardo, one more thing about all-on-4 concept and those beautiful cases that you showed. I noticed that in some cases, like the palatal approach, you mentioned that we can leave the threads exposed, and because we have a thick tissue on the palate, so we can have a seal of the soft tissue and no worries bone grafting exposure. Nowadays, we have hybrid implants that on the distal parts polished, and in the apical or middle part, they are rough surface. So in cases of those treatment protocols like palatal approach, or in the cases that you think that implant's going to be exposed, do you prefer to use hybrid implants? I mean, put the machine surface in an exposed area, or there is no difference for you, whether it's, for example, SLA surface to be exposed or machine surface to be exposed?
Well, I will tell you what is my brief experience with hybrid type of implants. I'm not placed many of them, to be honest. I would say around 10 or something, but the feeling that I got with those implants is that I start to have bone loss after 1 year, 1.5 years of the polished part of the implant. And I remember Tomás Linkevicius talking about the same phenomenon, and it's also written on the book, The Zero Bone Loss Concepts, that this type of hybrid surfaces will lose the bone up to the area where it starts to be a rough surface. So I would not go for this type of implants here, because we want attachment on the buccal part of the buccal bone. In the other part, in the palatal part, we have the sealing of the soft tissue. So I never try these implants in this technique, but what I would think about it is that I may lose crestal bone on the buccal part if I use this type of implants. So I would not, if I would have to guess, I would not say it's a good thing to do, because this type of surfaces are being abandoned, right? And but there is also another question here. There are hybrid implants like the Straumann level, for example, that the polished collar, it's supposed to be above the bone, right? It's super crestal. And I think your question.
Sorry to interrupt you. I didn't mean the polished collar. I was meaning by the machine surface thread, not the.
Yeah. Yes. Yes, but I was talking about it. I was just trying to clarify if we were talking about the tissue level implants or bone level implants. But my first answer was to bone level implants with a little bit of a polished collar, right? It was your question. But yes, because bone loss tends to happen until the implant starts to be treated, I would not use it. But to be honest, I never did it in an all-on-4. I never used this type of implants. And after the latest readings that I have seen, mainly from Tomás Linkevicius, I don't think I will try to go with this type of implants. Plus, we have the multi-unit abutment. So the multi-unit, it's the polished part that we don't have in the implant, and the adhesion will be also at the color of the multi-unit. So I really never had a bad experience in this type of approach. But that's the question. The thing is the soft tissue quality and the keratinized tissue all around the implant, and if we achieve that situation, it's very, very safe technique.
And Bernardo,
But what do you think about it? I'm curious to hear your opinion as well in this subject.
because one of the concerns, actually, the reason that I asked the question was this: one of the concerns that usually people have is peri-implantitis in the feet. And usually when we have a part of the implant, like the old Brandemark implants, that the whole length of the implant was machine surface. So usually the machine surface area, we don't really have that much plaque accumulation. And the rate and the progression of the peri-implantitis is going to be lower, and the patient have the chance to easily clean the area. But in the cases that we have a rough surface, in case of peri-implantitis or any inflammation in the area, the bacteria accumulation or infiltration can go easily more apically. So the reason that I asked was this, because as far as everything is good and patient is under control and hygiene is perfect, it's good. But my question is, when we have only 4 implants, and one of the implants, especially the tilted one, when they get in trouble and when they face peri-implantitis or progressive resorption of the bone, what will be the next act of the dentist, and how we can have the survival of that implant? Is there any way to save that implant, or is it easy to substitute that implant with the new implant because it was angulated? So I wanted to know about that maybe complication that may occur during such treatments.
Yes, yeah. It's very interesting point, because it happened to me one time in one case of a palatal approach like that one I showed you, and I lost the tilted implant. I lost, no, it's not true. I decided to remove the implant because I was having peri-implantitis in that implant, and my decision was, I will take this implant out sooner than I will in normal implant, because I don't have much more room to solve this problem here. So when I started, we tried the usual stuff, try to remove all the debris, try to clean the surface, try to polish the surface and everything. It didn't go according to what we wanted. So I just took out the implant, placed another one in the same day, and it was I think it was the best decision I made for that case, because now we don't have any problem in the other ones.
So you renewed the prosthesis, or you was able to use the same prosthesis for the patient?
Sorry?
I mean, when you placed a new implant, did you renew the prosthesis, or the same prosthesis was used?
This case I am talking, the patient was with the full acrylic, the immediate loading prosthesis. So it was very easy to take the implant, place another one in the same day, place the cylinder, and add immediately to the prosthesis. So in a patient perspective, nothing has changed. It was one implant, and now it's another one, and yeah. So yes, but it's a problem when we have a final prosthesis and we change the implant. We have to do another one. Yes, but it's working on the limit.
Yeah, and Bernardo, I noticed, because I think you are very expert now on full concept. You can place them easily the way that you want. I have two questions regarding that. One is that do you do these procedures under local anesthesia or under general anesthesia? And number two is that do you use guides for all-on-4 or I mean guided surgery? Because I'm talking about your recent post on Facebook and I really like that post. So I just want to open it up a little bit. You know what I'm saying? So I want to know, do you use guides for all-on-4 or for experienced surgeon, there is no need for use the guides? Because the way that you went between the lateral wall of the nose and also the anterior border of the sinus, so for those beginners or not an expert in the field, I think it's not really easy to go without the guide. So I wanted to know your thoughts on that.
Okay, I will start. I will start by this last question. It's the guides. You know, I am very critic of guided surgery. I think it's destroying a whole generation of could be great surgeons, and they are trusting too much on the guide, and they don't know how to work without it. You know, it's like. It's a false sense of security. But answering specifically to your question, no, I never used a guide on an album for ever. The positioning of the implants that we see very close to the sinus and everything, it's a combination of factors. So we have the OPG, which is a very good complementary diagnostic exam, because for the all-on-4 technique, the OPG shows the relationship between a lot of landmarks: the nose, the orbit, the sinus, the positioning of the crest, the pterygoid bone is also possible to see. If we have teeth or if we have defects, we have the relationship. So how far are one teeth to another, one teeth to a defect? How far is the anterior wall of the sinus to, I would say, to this teeth over here? So we have a very good way to try to, in our head, to see what we are looking at the OPG and what we are looking in our patient's mouth. Also, we have the CBCT scan, which is also very good, but it's not so good to see the relationship between things. The OPG is, in my opinion, is more useful. And we also have anatomic landmarks, and I use them in every case. Like, for example, by opening a big flap, by seeing where is the nose, and by opening a little bit to the zygoma bone, we see very well the convexity of the sinus. This is my main landmark, is the convexity of this by just looking for the bone. And looking at that, looking at the OPG, looking at the CBCT, with experience, it comes very natural for you to place the first drill, you know, the first pointed drill, okay, and you don't feel, okay, I'm not in the sinus, I'm sure I am on the bone. Then you place the 2.0 millimeter, just go slowly, okay, it's everything bone, and then I use a perio probe. So if I feel everything is bone with the perio probe, actually I don't really use a small X-ray, you know, like placing the first burr, taking an X-ray, see where is the sinus. I don't do that anymore. It's anatomical landmarks, it's the exams, and it's probing the first drill that I use. If by some reason I enter on the sinus, I know, okay, 3-4 millimeters on the side, and I am on the right spot, and it's just like this. And for the second question, the anesthesia, I would say I have done like 5 or 6 cases under general anesthesia, because the patient asked to, very anxious, but it was never because of me, you know. It was always because of the patient, and I tried to go on local anesthesia and try, but the patient didn't want to do it, so we went general. But yeah, but 99.9% of the cases with local anesthesia, even maxillary cases.
And the reason that I asked about the guided surgery, some people use guided surgery not for only placing the implant in the right direction, but for giving the patient the provisionals on the same day. So they have the chance to make the guide, make the provisional before patients coming, and then use the guided surgery for delivering immediately. So do you also believe in that, or the reason that you said that you don't believe in guided surgery was only for upper implant placement?
Uh, let me just let me just say it's not that I really don't believe in the guided surgery. No, of course it's very helpful. Of course, it will be part of the future and the present. And I use guides for the superiosteal, as you've seen, because we have to place the guide to make the bone reduction in the appropriate places. But you know, for full arch surgery. The experience that I have seen, because I've seen a lot of colleagues using with me as an assistant, they took more time using the guide than I take doing freehand.
Yeah.
So for a surgeon perspective and for a surgeon perspective to improve yourself and to be better and to really know the primary stability you are using, because you know, using guides, sometimes the friction that really in the guide makes you a false sensation stability. I don't think it's the way it's the way to go on mainstream. But you are, when you say that helps a lot with the provisional prosthesis. And nowadays we are seeing these type of stackable guides. We also have very good colleagues doing this, a guide for the reduction, a guide for the implant placement, and then also the provisional prosthesis on top of that. I think that can speed up the process quite a bit. Although I must tell you the truth, Omid. We always do immediate loading 3-4 hours after the surgery, and we are not going guided. So I think at the end of the day, it's a matter of good protocols of working with a lab. And most of the times, my lab technician is not on the same clinic as I am. So we still have that time, you know, going forth and back with the things. But yes, we are still doing 3-4 hours after. So it's a matter of prosthetic protocol to be very, very rigid, to have everything set up. And I really don't feel necessity or advantage in paying for the guide and wasting time and money on that, you know, because planning a guided surgery, if you are going to do it by yourself, it's like you spend 1 hour on the surgery and 2 hours or 3 hours planning the guide. That's valuable time. And we all have our family and friends and personal things to do, and I try to spend the minimum time on the computer. This week, this session with you is the biggest time I'm going to spend on the computer, unfortunately. But it's a big pleasure.
Thank you so much, my friend. And my last question is regarding the angulation of the tilted implants in all-on-4. You mentioned the 45 degree, okay? So I want to know if there is a difference between 30 degrees and 45 degrees. Is it possible to also place them in 30 degrees, or it's a must place them in a 45 degree angle?
Yes. Yeah, very nice question. Originally, the all-on-4 technique was supposed to tilt 30 degrees, and then the multi-unit will correct degrees, so the implant will be straight. What we are doing today is not going for 30 degrees, but to go the same angulation as the wall of the sinus. So that is my angulation. It's not 30, it's not 40, not 45. It's the same angulation of the sinus if possible. And it's actually by tilting more than 30, like 40, 45 degrees, we will have a leverage of 10 or 15 degrees because the cylinder will be pointed distally. So that will mean that in the prosthesis, the axis will go distally. And because all of the fractures, if they occur on the cantilever, we are reducing the amount of cantilever. Sometimes we are eliminating all the cantilevers. So it's a benefit. It's not tilting more than 30 is benefit. Yeah.
Yeah. Thank you so much, Bernardo. You know, one of the hot topics on hot seat as a first session. So there was lots of questions. It was full of knowledge for me, and I truly want to thank you for your time. It means a lot these days, and I appreciate it. It's an honor to have you, and I truly enjoyed every second. I'm pretty sure all the audience did. And once again, I want to thank you, appreciate you so much, and hope to see you very soon after all these limitations.
The pleasure was all mine, Omid. As I was telling you, this hot season, the hot seat season that you did was very, very famous all around the world. I'm sure everybody knows, everybody that is on the internet at least knows about this project. And congratulations for this. For me, it was a big honor to be here to share a little bit of these things. And I'm really looking forward to meet you in person after this pandemic.
Thank you so much, my friend. Stay safe, and just hats off for you, and enjoy your time, and God bless you. Thank you.
God bless you too. Thank you very much.
Bye-bye.